Hello, and welcome to Senior Living Simplified. I'm your host, Christina Hodak. You know, my background is geriatric nursing, and I have over a decade of experience dealing with pretty much everything there is to do with senior living in one form or fashion. I have sat with countless families and spent a lot of hours talking to them about trying to juggle their own lives, all while dealing with the complexities of maybe even trying to care for a loved one that's aging. That can be a lot to go through, which is where the development of the podcast came from. We wanted to have a place where people could come and get some information in just small bursts and segments and just kind of elaborate on all the different aspects that senior care has before there is a significant event, kind of arm yourself with some knowledge. So it's kind of like doing your homework. The only way I've ever known that you can get better at anything is just kind of diving in and finding out the information. So whether you are new to senior care, whether you have been in the industry for maybe 20, 30 plus years, it never hurts to hear information again. I personally find that I learn something new almost daily. And the only way you do that is to keep your mind open. So why don't we crack our books open and see what we can learn today on this episode of Senior Living Simplified. For today's episode, our focus is on hospice care and commonly asked questions. We might even dispel a few myths or two. We really want to talk about what hospice is and what it is not. So please help me welcome my guest, Waldo Rios. Welcome. Waldo is a geriatric nurse practitioner and founder of Nights of Comfort, Hospice, and Palliative Care. Welcome.
Thank you for having us. Yeah, we appreciate it, and we look forward to talking a little bit about what we do, how we do it, and why we do what we do.
Well, for the viewers out there, Waldo and I have worked together in several different cases within the communities. I'm the executive director of Sage Oak Assisted Living and Memory Care, and Waldo's company has aided a number of our families and just done a fantastic job. That's why I thought he would be a great resource to have on the show with us today. But before we start talking about hospice care and Nights of Comfort, why don't we take just a quick second to get to know you a little better, Waldo?
Sure. Really, thank you for opening this platform to kind of diving into hospice. You know, that's one of the things that we've really taking upon us to kind of put it out there. Nobody likes to talk about hospice, but it's very important because we're all on this journey. We all have an internal clock that is ticking, and it's very important to approach it with an open mind. But really a little bit about me. We'll first start with the name, just get the elephant in the room, address it. My name is Waldo, but you know, and I hear words Waldo all the time. I probably heard it 2 times on the way over here from a patient or a family or some friends. But my formal name is actually Waldfeld, German first name, and Rios is my last name, Spanish last name, and that came from my father, who was a classical music fanatic in Nicaragua, and that's where my family's from. So he named me after Mozart, Wolfgang Mozart Waldfeld, and my older brother's name, Ludwig, after Beethoven, and my younger brother got the Egyptian name Ramses, and my mother decided no more music names, and so. Coincidentally, we actually ended up being classical musicians before I embarked on this medical career. And that started really in elementary school when a 72-year-old retired violin professor came to PE. And I can remember, you know, I was sitting there just wondering what this gentleman was about to do. And he was recruiting for the orchestra program. And so when he said the only catch is if you join the orchestra program, you're gonna have to skip PE. For me, it sounded like a deal, so I decided to say, sign me up. A week later, I was handed a violin, and fast forward through it, what ended up being a hobby became something we were naturally gifted in, and I actually went to music school. In high school, I was part of a scholarship program with the Dallas Symphony that really allowed me to take private lessons from a Dallas Symphony musician, which otherwise our family wouldn't be able to afford. And that really led me to go to a New England Conservatory, which is a music school. When I got there, as a way to escape the conservatory lifestyle, music, performing music, everything, chamber music, orchestra performances every other day, I really kind of went in another direction, just to kind of give my mind a mental break. And so went on this health and fitness journey that essentially led me coming back to Texas and graduating in exercise physiology, and then leading exercise programs for rehabilitation, for workers' comp and physical therapy. And so, but then that naturally led into exploring nursing as an opportunity to really kind of have an open mind in different pathways. And so, and then ultimately I decided to go to TCU for nursing school, and ended up going to University of South Alabama for my graduate studies in adult and geriatric care.
Awesome. Thank you. I started this by saying that I tend to learn something new every day, and I just did today. I've known you, but I didn't know you were a classical musician, so you can still learn things every day.
I don't look like a classical musician, but I can play a violin. Yeah.
That's very cool. I bet your patients love that too, if you were to break that out.
Yeah, actually, I have an opportunity to use it on, as one of the therapies in some of our communities. So.
Well, I'm committing that to memory, and we'll definitely talk more about that for hours later. Well, so why don't we start with kind of defining hospice for the viewers? What is it? What are some of the bullet points that you think are important for people that have no knowledge of hospice? What's something great that they could know?
Great question, really, because when I kind of landed in the hospice world, and I'll kind of talk about that here in a minute, I didn't even know really what hospice was. I came from a Hispanic family. We don't talk about death and dying. And so really that made me really kind of open a door to something I didn't know was out there. And we'll start with the word hospice, which its origin is Latin, and it actually means guest or host. And it actually originated in the 11th century, where travelers and pilgrims were guests in people's homes as a hospitality measure. And then later on in the Crusades, it's thought that the first hospice kind of originated in dealing with terminally ill and injured soldiers. And so, and that's actually kind of where the name Knights of Comfort started too. Our logo is the knight, and we look at it as a representation of the heart in the middle, which if you look at our logo, there's a heart inside the helmet. And it really kind of drives our protecting, which is the helmet, the heart of the patient and family. And really, as far as hospice to what we know today, it really was revolutionized by a British physician that's very known. Her name is Cicely Sanders. She essentially revolutionized, the type of hospice care that we know today, the type of philosophy, and the many services that we've kind of come to understand. And really, the hospice philosophy is to provide care for and dignified care for those that are terminally ill and need us during that time.
Yeah, so you say that hospice is for people that are terminally ill. How does someone know if they fit that definition? Is it their physician that discusses that
Sure.
with them, or would family just, maybe a physician hasn't told anybody, but families are curious, would they also just reach out to you guys to find out?
Yeah, great question. Because I get a lot of families call us, and they've never gone through this experience, and it can be real confusing when you maybe hear from a family member or a friend that says, "Hey, have y'all considered hospice?" and you don't know where to go from there. It usually naturally starts from a physician referral. So, let's say I was a patient at a cancer center, and I've tried therapies and chemo or radiation, and none of it's worked. Well, at that point, there's a very important decision to make. If progression of illness has continued, what is the next step? And that is the conversation that a physician normally initiates. And usually where we begin is getting that referral from a physician. But in many instances, we receive phone calls from families that are just looking for information. And frankly, we encourage that, even if hospice hasn't even been spoken about. Because sometimes hospice is elected too late, where we don't have the opportunity to provide our services to its fullest potential. With every journey, it's different. We have patients that we have on service for a day. We have patients that we have on service for more than 6 months. But it all starts with just us understanding where a particular case is and kind of navigating from there.
Yeah, I agree with you that it's better for families, even if they don't know if they have their family member has a terminal diagnosis, or if there's not a clinician that's necessarily initiated it. It's much better for them to reach out beforehand, get the information, because when you come to that fork in the road where you need to make that decision, that's a very emotional time for a lot of families. So getting the information when you're not in that terribly emotional state is going to be better for them in the long run, because they will have had time to process the information before it's time to execute on that.
I agree on that, and that's why we like doing, podcasts like this, where we can kind of explain and kind of put the misconceptions to the side. Really seeking information and just asking questions, and kind of getting our take on certain where your loved one may be is important. Sometimes it's just really kind of hearing encouraging words, even if it doesn't mean that this particular individual may be needing hospice. Ultimately, we're community providers, so we'll point you in the right direction. And we're fortunate enough to work with people, like Christina and the Sage Oak communities, where they encourage open communication.
Yeah, that's something I can definitely attest to that happens with Nights of Comfort. We've had a fantastic track record of communication with you guys, and I can't tell you how much that's appreciated by us and the families that we serve together.
Sure. Yeah, and that communication aspect is very important. These families that call us or are needing hospice really just want a little hope in the midst of what may seem hopeless at that time. And so, in collaboration with assisted living communities or, family members, we like to approach it as, we're real individuals. We're not here to sell a product. This isn't a product. This is a service that comes from the heart. We take it really as our ministry to really deliver the type of care that I would want if it was my dad involved.
Yeah. So let's kind of dive into, we'll assume that a family is ready to elect hospice, they're needing to move forward, and they've elected Nights of Comfort. So one of the questions that I get a lot when I'm at the table across from these families is who pays for hospice? So if you can talk a little bit about who pays for it, and then what benefits are included with
Great.
going on to the services.
Yeah, that's a very common question. Who pays for it? How much does it cost? We get that often, and I was too surprised that Medicare covers for, frankly, most of these services, including some private insurances too. And depending on each agency, different agencies may accept different private insurances: Blue Cross Blue Shield, Aetna, Cigna, and whatnot. So it's good to seek out that hospice provider and ask them whether they take that insurance. But Medicare essentially is our primary population group. And really, what does that include? When that decision has been made that hospice is going to be elected, it covers medical equipment, so hospital beds, wheelchairs, oxygen, the standard medical equipment, suction machines, and really even things that may not be part of the standard. We look to cover too. Incontinent care supplies like pull-ups, briefs, and things like that, wipes, gloves, and that comes part of the hospice benefit. But the core benefit of hospice is really the multidisciplinary aspect of care that includes the clinical care, the emotional care, spiritual care, not only for patient but their family too. We're talking about nurses, nurse practitioners, physicians that are going to be actively involved in navigating through this journey and really molding it to fit what you need. And in addition to chaplains who focus on spiritual care and social workers who are there to help with arrangements or questions on advanced directives, etc. We also have music therapists, we have volunteers, we have certified nursing aides that take care of your loved one on a day-to-day basis, and so it's many different disciplines that are all well equipped to provide the care that their loved one may need at that time. What does hospice not provide? Any sort of aggressive therapy, elective surgery. Let's say I elected hospice and want to seek curative treatment. You're not in a contract, so at any point in time you can choose to actually get out of hospice. We need to know, and keep in mind it's not a contract; it's an election of service. So, and we always like to be upfront with families about that. So it doesn't bind you to a certain, election. It's very fluid, but it doesn't cover elective surgeries like hospitalizations, funeral arrangements. It doesn't cover funeral services. But all in all, it's the hospice care benefit is pretty comprehensive, and really depending on what illness is involved, it kind of differs on what sort of needs may arise. So, for example, somebody with Alzheimer's may need more wound care supplies if they have a wound versus somebody that is actively mobile and maybe has COPD or congestive heart failure or something like that. So it's very fluid in what we provide.
Yeah, it's very individualized too. I think when you were talking about the fact that it's not a contract, you're not committed. If you elect this service, you're still in control, right? The family's still in control. The patient, if they're still able to make those decisions, is still in control. I've seen it several times in my nursing career and as an executive director where someone that's with us, they're not doing so great in their current setting. They move in with us, they elect hospice services, and between hospice and the services that are provided and the community, all of a sudden they have all this extra care, they start doing better. And then they do want to get back into, maybe now they want to work on physical therapy to get stronger because they're doing so much better. They can come off of hospice. It's not a life sentence.
Correct.
Essentially, it's always their option.
Correct. Yeah, and we like to have those patients that actually graduate from a hospice program because our goal isn't to withdraw improvement. On the contrary, our hope is that there is improvement enough that our patients can actually benefit from this comprehensive style care and hopefully reach a plateau where they can graduate from hospice.
Yeah, I think that's definitely worth noting. So let me ask you a few myths. These are things that I have actually heard people believe from information that they probably heard secondhand more than looked into. But the first one is when you're on hospice, they take away all medications, and I'm afraid my family's going to suffer because they need their inhaler, they need their hypertension medication for high blood pressure. So talk about that.
A very common myth, and it's unfortunate because that deters a lot of families from kind of seeking, information. But no, and on the contrary, family is the core decision maker, or patient is the core decision maker of what they want, and so removing any sort of medications would only be brought up if it's recommended. So, for example, we have patients that are actively declining. At that point, perhaps some medications aren't tolerated in tablet form and they need to be switched in another form. And so if it places the patient at risk, then the recommendation is always given, but it's not it's not forced.
They're still in control.
Correct. And so we like to kind of be upfront on, and also really kind of do a comprehensive medication review to tell them the justification of each medication. A lot of families come to us and they have a list from maybe after rehab or after the hospital where they've been on 30 meds and not even they know what they're for. And so really consolidating them and making sure that they know what each one is for and why each one is given, certain side effects that may affect their diagnosis is very important. And we like to, more than anything, educate on each medication.
Another commonly asked question that we get from families is when they stop needing, or they stop being hungry, they're not taking in fluids, they're afraid that their loved one is starving or they're going to be dehydrated. What is your response when families are concerned with nutrition? Valid
point, and a very common question and concern we get. Top 3 of most common questions asked, I think, is my loved one starving to death? And that comes really from our our natural drive to eat 2-3 times a day. When we're dealing with a particular illness, terminal illness, and a declining metabolic system, different levels of nutritional intake may be counterproductive to comfort at that point. And it's really on a case-by-case basis, but what I like to tell families is when you and I are sick with the flu or with the virus, sometimes we just want to go to sleep and not eat. Same thing happens, but to a greater degree, where multiple systemic factors are affecting the priority of a body asking for food and water. And it follows a certain template, a declining body in a declining system. And but a part of it comes from really being educated on the reason for continuing food and not ingesting food because on this end we're used to it. In fact, research kind of shows that oral hydration via swabs to a certain degree during the end life stages is more comforting than providing, actual fluid because of aspiration risk. And so there's many different factors to consider when we're talking about end of life care.
Yeah, the system doesn't have to work as hard
Correct.
to do all of
Correct.
that.
Yeah.
Well, I am so glad that you came. I think that we could probably talk for far longer than we have today to really get into everything that you guys provide. But for people that are interested in hospice care or wanting to learn more about it, where can they locate you?
Yes, you can look at our website. It's knightsofcomfort.com, Knights with a K, Knights. There's also an email there, ask@knightsofcomfort.com. But we encourage anybody to call, really, if they're just looking for information. We like to speak with people, and or if there is maybe a direction we can point you to, then we're more than happy to do so. And so, thank you so much for allowing us to kind of speak with your listeners, and we look forward to being guests here another time.
Yeah, absolutely. Thank you. As always, if you or someone that you know is seeking out assisted living or memory care services, maybe you're just curious about it, please give me a call. You can always find us at thesageoak.com. You'll have my contact information on the banner there below. You can also always leave comments in the section, and I'm happy to set up times to speak with anyone. So thank you for spending your time with us today and learning about hospice care and Nights of Comfort. And I look forward to seeing you guys back next time on our next episode of Senior Living Simplified.